So it's time to introduce the first speaker of the day. We are very proud to have here Dr. Margaret McCartney. She's a practicing GP in Glasgow and a columnist for the BMJ. She's also a broadcaster at BBC Radio on the theme of evidence-based medicine and a published author of several medical books. The theme of her talk today is life, death, and sexed-up medicine. So give a warm welcome to Margaret McCartney.
I brought some snacks. Good morning, and thank you so much for having me. It's a real pleasure to be here among such a vibrant group of colleagues. You're the best looking audience I have ever had. Okay, so these are my declarations of interest. I'm a GP partner. I write and I broadcast. I do freelance journalism. I don't work for any PR company or do any company work for drugs companies. And I'm the chair of the Royal College of GPs Overdiagnosis group, unfunded but very vibrant group. And my declarations are at Who Pays This Doctor, which is an open website for anyone to publicly declare their interests if they would like to. So this is the problem. Over the last 6 months, I've been collecting the kind of things that people say we should be doing as GPs. So these come from newspapers, from policymakers, from politicians. GPs are ideally placed to stop obesity, stop health inequalities, save marriages, especially the silver splitters. If you're in your 60s and bored with your partner, your GP can help, apparently. Stop terrorism, save money, diagnose cancer early or stop cancer occurring in the first place, stop online bullying, give sex education, stop teenage pregnancy, stop people smoking and drinking too much, and stop people from not doing enough exercise. Doctors, this is how we should look. Even the men. In fact, especially the men. So we have a newspaper in the UK called the Daily Mail. I don't know if you've heard of it. It makes me cry. These are the kind of front pages that we have. GPs are terrible in every way. We are denying people treatment. We are dangerous. We are lying. We don't work hard enough. We're just rubbish. And this is really what it makes me feel, which is a bit unfortunate. So why are we so stressed as a profession? Well, consultation rates are up, we know this. Our consultation times are longer. Our workload is up around about 16%. It's not sustainable, but really how much of what we do is actually useful? We're in the industrial era of medicine. We're underfunded, we're overstretched, and there's a belief from our politicians that somehow medicine can sort out failed politics. Our medicine that we offer people has been sexed up, overhyped and oversold. And we've got this patient paradox where people who don't need our help end up getting a lot of it through screening and are overdiagnosed and overtreated, whereas people that really do need help, especially mental health care, have to battle their way through a system that seems designed not to help them. This threatens the moral contract of medicine and of the NHS. And where is the fun in that? How can we enjoy our jobs when it is so difficult to get through the day? And this era, I feel, has led to tick box diagnosis, where we ask people to fill in questionnaires about their mood sponsored by drug companies, rather than looking at people face to face and asking them how they are feeling and getting to know them. It's led to a whole new specialism of risk factorology, where we try and predict the future using fairly dodgy tools. We base our decision-making on studies that have used surrogate outcomes that exclude many of the patients who are our normal population, which often give people slender or even no gains, and which keep concentrating on disease-specific mortality rather than all-cause mortality, and make interventions look far better than they actually are. And as we are encouraged to find things earlier and earlier, we are increasing the risk of overdiagnosis and subsequent overtreatment. And of course, all this leads to disappointment, professional disappointment, policymaker disappointment, and patient disappointment. Because how can patients be well served in a system that works like that? The big problem is that interventions that don't add value can only harm, either by harming the patient or by harming the system, by spending resources at things that simply don't work. This is a cartoon by the wonderful Hilda Bastian. I encourage you to look her up online. Things got really interesting when the statisticians started doing ward rounds. Does it work? Well, that depends on what you mean by does it and work. This is what we're living with now. You've all seen these graphs, famous graphs now from the Lancet, showing that as we get older, we start to accumulate more and more disorders. And that, of course, means that we start prescribing more and more drugs. Our drug prescribing has increased year on year on year. That means more work, more prescriptions being generated, more time to do that, more pharmacist time. It places a big strain on the system. But how many of them are actually useful? Well, this is a review looking at guidelines published in the BMJ, which looked at 22 NICE guidelines with 495 recommendations for primary care. But only 38% of these recommendations were based on patients typical of us, of whom we seem in our community. Is that safe? I don't think so. Here's another study showing that drug disease and drug-drug interactions are a big problem where we start following guidelines. The more guidelines we're following for more patients who have more and more multimorbidities, the bigger the chance of an interaction between the drugs, because we are treating patients as owners of single diseases when the reality is much more complex. GPs know this, and it's a huge, huge problem, because we are judged to be good doctors when we follow guidelines, and we are judged to be giving poor quality medicine when we don't. And the bigger problem behind all this is, of course, opportunity costs. Do you have Ferrero Rocher in Iceland? No, you won't get this joke. Okay, I'm going to tell you, these are Scottish delicacies. They're called Tunnocks tea cakes. Would anyone like one? It's just to waken you up. I have more. You can have more later. So when we have a party in our house, you can buy big boxes like this, and my children love them. And they know that when other people come to the party, other people will eat the Tunnocks tea cakes. So they get downstairs early and they eat them all, because they understand opportunity cost. If they don't take the resource, somebody else will get it. Okay. So I'm quoting here from the NICE guidance on statin prescribing. And this guidance suggested that GPs should start to prescribe statins when there was a 10% 10-year risk of a cardiovascular event rather than the current 20%. And in the expert guidance it said, expert opinion suggests that there is insufficient capacity within existing primary care resources to meet the increase in demand as a result of implementing the guideline. If we do this, what do you want us to stop doing instead? That is the question, and it is not being answered. If we treat more people at risk of a disease who don't actually have the disease, what patients who are suffering with illnesses and symptoms who need our relationship with them do you want us to stop seeing to fit that in? And that is the problem that policymakers simply do not answer. The other big problem is that for patients, being a patient with multimorbidity is very, very hard work, and it is really under-investigated. This is one excellent paper examining it. Depending on the concomitant chronic condition, patients with 3 chronic conditions complying with all the guidelines would have to take a minimum of 6 to a maximum of 13 medications a day, visit a health caregiver a minimum of 1.2 to a maximum of 5.9 times per month, and spend an average of 49 to 71 hours a month in health-related activities. Who can do this? The expectations placed upon patients are enormous, and of course it goes up as the disease goes up. 18 medications per day, 6.6 medication visits per month for people with 6 chronic conditions. An extraordinary amount of work they were asking patients to do. And the promises being made for patients who don't have any symptoms are also enormous. This is a leaflet from the free NHS health check advertised widely. It's very unclear how much money has been spent on it, but millions of pounds. And it claims to help prevent heart disease, stroke, diabetes and kidney disease. Well, does it? No. We have the excellent Inter-99 study from Denmark, and of course Peter Getsch's work, showing us that health checks and screenings simply do not reduce mortality and morbidity, and there has been other work showing that in fact GPs are very good at diagnosing chronic conditions given the resources to do the work themselves. We don't need an expensive external program to add to the problems of overdiagnosis, overtreatment, and overtesting. And I'm very concerned that the algorithms that we use are themselves inaccurate. This is a really useful graph from the BMJ a few years ago. The grey box is the total population of men and women. The yellow box are the people in that population who develop cardiovascular disease. And the blue box and the pink boxes are either the QRisk2 risk assessment tool or the NICE Framingham High Risk tool to identify those patients. If this was a good risk calculator, the yellow box would overlie one of the risk calculators. It does not. Look at it, it's a mess. We are picking up people at high risk where they do not have a high risk of developing cardiovascular disease, and we are missing people as well. So we're doing lots and lots of work that don't actually benefit people because these people were never destined to go on and develop cardiovascular disease. But this has not stopped a huge amount of effort that's gone into encouraging people to get their blood sugars checked as a screening test. The first advert I took a photograph of when I was buying gin and chocolate in a Tesco supermarket in England. And at the till, there was a sign saying, "Could you be at risk of diabetes?" And on my till slip, they encouraged me to go and see the pharmacist at the counter to have a blood sugar screening test done for diabetes. I don't know if that happens to people that are not buying gin and chocolate, but I went to speak to the pharmacist and she said, "Yeah, I know it's not good medicine, but we are paid to do this. I have targets to meet." And I thought, well, that is terrible. But then I thought that is exactly how I am operating in general practice too. It is scandalous, it is appalling. The other adverts were placed by Diabetes UK, a charity in Britain, encouraging people to get their risk of diabetes checked. And you'll see all kinds of claims made. If you don't check your risk of diabetes, then you're risking stroke and amputation. If you don't check your risk, then you're not doing it for your family, you somehow don't care about them. There's a huge claim being made here that testing is good for you, and yet we know from the Cambridge Addition study that screening from type 2 diabetes does not impact on mortality. So we have really good randomized control trial evidence that we keep abusing because we don't pay attention to it when it's been done. Okay, so if you get your pens and paper out, we're going to do a little quiz. Okay, and I'm serious. I'm not serious, don't worry. Okay, so screening for a deadly disease, okay. 0.3% of the population have a deadly disease, and you have a test for the disease that's 50% sensitive. And we know that there is a 3% false positive test rate from this test, and you test positive. So how likely are you to have the disease? Okay, so this is generally how I feel when I'm being given sums like this to do at any time, not just early in the morning. I generally feel very uncomfortable with it. But then I read Georg Grenzer's book, which is fantastic, Reckoning with Risk, and I highly recommend it because it makes it so much easier. So there's actually about a 5% chance of really having the disease if you test positive in these situations, much lower than most people think. And the way to work it out is easy. So you have 1,000 people, and we know that 0.3% of them have the disease, so that's 3, and we know that 997 people do not have the disease. We know the test is 50% sensitive for diseased people, so it will pick up 1.5 of those 3. But we also know there's a 3% false positive rate for those 997 healthy people. So 3% of them will test positive, that's about 30. So your positive cases in total are the 30 from the healthy group and 1.5 people who really do have the disease. But we know that only 1.5 have the disease out of that total of 31.5, which is just under a 5% chance. And Georg Grenzer has run this kind of test with doctors, midwives, patients, and everyone gets it wrong. It's very uncommon for doctors to get it right. And that's really problematic because a test that looks quite reasonable to do actually performs really, really badly. The problem is not the maths here. I think it's the underlying psychology that what looks like quite a good test actually turns out to be really, really bad. And we end up in all sorts of problems. In Scotland, we are told, don't take a chance, take the test. But if you take the test, you're taking a chance. And this is a famous actress saying, I choose to do it because it could save my life. Well, no, we know that screening mammography does not do that, possibly disease-specific mortality, but there are lots of harms attached to it as well. And it says at the bottom, don't get scared, get screened. I would argue, don't get scared, get some really good evidence and try and decide what to do about it. Because until you appreciate that when we diagnose things at an early stage, we often create overdiagnosis, we won't know whether we want to have the test or not. And this graph here just shows when breast screening was introduced, you can see exactly when. That's when early stage diagnoses of breast cancer go up, but your late stage detection rates don't change. And that means that you're not actually saving lives. You're not actually managing to reduce your late stage presentation rate because these are different types of tumours that are not going to be picked up by screening. This is the kind of information we should be giving people. Fantastic, wonderful, clear and plain examples of just what the benefits and risks are of breast screening. So here we have on the left side 1,000 women without screening. We can see women who died from breast cancer in the top left-hand corner and the women who died from all types of cancer alongside them. And in the other column, we can see that actually we are over-treating. All those blue women that are coming out there are women who are being given false alarms or either treatment for a breast cancer that was never going to harm them had they not had the breast cancer screening. And that's the kind of information I think we should give people in order to de-sex medicine, make it much more boring and plain so that we're giving people helpful information to make proper informed choices. Again, this is PSA screening. We can see exactly when PSA screening started with the blue horizontal line. We don't improve the mortality rate from prostate cancer screening. That's down at the bottom, that's staying constant. But we massively increase the amount of prostate cancers that are diagnosed. That doesn't help people. That puts resources where they're not going to benefit individuals. That can't be good for anyone. We've got a really difficult issue with how much we overestimate our own benefits from treatments. So physicians, when they're asked their views of treatment, tests and screening, fantastic review by Tammy Hoffman, found that physicians overestimate the benefit of our interventions a third of the time and underestimate the benefit only 9% of the time. We underestimate harms 34% of the time, and we overestimate harms 5% of the time. So we oversell what we think we can do. But that's, of course, very difficult when many of the trials don't actually address harms in cancer screening at all. So this was a review published in the BMJ a couple of years ago, finding that cancer screening trials seldom quantify the harms of screening. So how can we tell our patients if we haven't done the basic research to start off with? So this is the kind of guidance I find really useful in primary care. You can Google this, NHS Highland Polypharmacy will bring it up. A really great list of numbers needed to treat, which I find really helpful when doing medication reviews with patients. And when I start to say to people, well, actually, we have to treat 104 people like you in order to delay one death. It's not saving lives, it's delaying deaths, because we're not that good. We're good, though, but not that good. People often say, well, actually, I don't want to take that because I'm having so many side effects. It's not worth a 1% chance of me benefiting. I don't mind. I'd rather not take it. So until we give people really good information, we're not going to know the impact. And we do know that the better information we give people, the less likely people are to want the interventions. So I think we need a bit more lagom. I said I was going to tribute to Sweden. I have been to a Sabaton concert. They're heavy metal, you need earplugs, but they're very good. It's a fantastic word, this lagom, just enough, just taking your share but no more. And I think that's what we need to get back to in medicine. But the problem is when GPs are disempowered, we can't do that anymore. If we work to demand a market system, a customer-based system, we will give people what they want, not what they need. Because many people with needs will not approach us, they will not ask, they will not push themselves forward, they will not operate well in a market-based system. And at the end of the day, we are still going to die, no matter how well we try and treat people, how we try and diagnose things early, how much we try and treat risk factors. At the end of the day, we are still going to die. And this is a beautiful lithograph from a biography of Lincoln, describing how when he was shot, he was brought back to the White House to die. And his colleagues came around him to tell him how much he meant to them. He had his family around about him and his wife. He was treated by his physician and he died very gently. in his own bed, in his own home. And I think that's a death to aspire to. Whereas we have this real problem with the battle mentality over cancer in particular in the UK. So I pay my children £1 for every advert they can find that they know will annoy me. And this is from the local cancer hospital who were advertising for money. Be full of hope, be courageous, be ready to fight. I had patients who were in tears because they felt that they weren't fighting enough, and that was why their cancer was killing them. And I really feel that we are so harmful when we don't mean to be, we don't even know that we're being so. There is really good evidence that your coping style, including fighting cancer, makes no difference to how you get on. It doesn't impact on survival. And worse than that, many patients described how feeling that they had to fight their disease or their cancer, it somehow meant that they were resisting the expression of emotional distress, so unable to tell their doctors or their families how they were feeling. And that's tragic, because when we can't have full and frank conversations, we will end up doing the wrong thing for people. It's even more tragic when we know the data about the difference between active treatment and palliative care. So again, a really famous graph now from the New England Journal a few years ago, looking at the difference between palliative care and standard care for non-small cell lung cancer. And as you can see, standard care, people lived less long than people having early palliative care. And I think part of the reason for that is because we stop doing harmful things at the end of life. We stop giving people neutropenic sepsis by giving them chemotherapy that they really can't benefit from. We concentrate on symptoms, what's important to people, what they would like to do. For many people, it's the simple pleasures in life, and we can facilitate that as GPs by advocating against overtreatment and helping people have the treatment that they know they want, which very often is symptom control and relief. And there's increasing evidence in other areas. This is, for example, people with terminal breathlessness, people who had very significant lung disease and had a huge problem with breathlessness as their symptom. And we know that palliative treatment for breathlessness, over and above their normal treatment, so basic palliative care techniques, actually made those people live longer and with a better quality of life. So it doesn't always have to be about chemotherapy and radiotherapy for cancer. Symptom control is really important. And I think as GPs, we can really help people step off the treadmill of things they don't want or don't need, and actually find out what they do want and need, and have a better quality of life before death. But all this is ruined by the Daily Mail, again, who had headlines recently saying, nurses on home visits told to ask elderly patients, do you want us to let you die? Over 75, sign here if you're ready for death. And this was the controversy about CPR and do not resuscitate orders. It became, I think, well known. There was a few legal cases in the UK where a patient had a do not resuscitate form put in her notes without her prior knowledge or her family's knowledge. The family sued, and it was upheld in the High Court, and the doctors were told it was illegal to put a do not resuscitate notice into the notes without having discussed it first with the family. And that basically has meant that everyone has to be resuscitated unless they have a do not resuscitate notice in their notes, which means it has to be discussed with everyone before we can't do resuscitation, before we can't not resuscitate them. So there's a huge problem, I think, because it means that more and more people will be resuscitated without good reason, because the form hasn't been done. So more conversations have to be had. And in many ways, that's a good thing. But the problem is our resources are highly limited. So this is the Daily Mail reporting on one gentleman who had a conversation with his doctor about resuscitation. There's a cancer patient who was left terrified after a hospital doctor issued him with a do not resuscitate order. A doctor told him he wouldn't be revived if he took a turn for the worse, which is an unusual way of describing death, but anyway. Huge amount of fear around it, and I think that fear is driven into doctors as well. So this is a form that we have to fill in Scotland if we are deciding that resuscitation is not in the patient's best interests. It's a very scary looking form We don't do this for any other treatment that we don't offer. We don't have a form like this when we don't send someone to intensive care. We don't have a form like this for when we don't offer a renal transplant. It's only for resuscitation. And you'll see you have to sign it and date it. Junior doctors have to have a supervising consultant's name on it. It looks like quite a scary form. I don't think I would fill it in for a hobby. And yet we know that CPR is something that really has been oversexed and overhyped. These are some soap operas. ER hasn't been on for years, but there's been good research about how many times resuscitation has been successful in these soap operas. So in ER, or Chicago Hope, 75% of patients survive CPR. Holby City, Casualty, 46% of people survive. And we know there is an association with watching more medical dramas on TV and having worse knowledge about the effects of CPR. So the research has been done. We know that older people overestimate the chances of CPR survival dramatically. One cohort in the US estimated their chances of survival as 80%. These are older people over the age of 65. 98% of US churchgoers so overestimated the CPR effectiveness, sometimes by 100%. I don't know quite if it's associated with the population they were drawn from, but generally the population don't get that resuscitation is not very good, and the data is pretty stark. Outside hospitals, 9.6% of people were survived to discharge home, and inside hospital, 17% will survive to discharge home. So it doesn't work very well. CPR in people who have cancer really doesn't work really well at all. So a series in JAMA, 243 people with cancer having CPR, and no one with metastatic disease survived to discharge home. So why are we doing CPR at all in these people? It's changing the nature of death from a situation where you could be sitting beside your family, being cared for by them, talking to them, being conscious, up until the very last moments of your life, compared with a situation where your family members are pushed aside in order to let doctors and nurses in to break your ribs, intubate you, put stuff into your veins. Is that really the kind of death we want to happen by default? I don't think so. Part of the problem is fear. We're working in a really fearful era. The industrial era of medicine, I think, has been accompanied by great fear that we will be judged and found wanting. Everywhere we go, we are blamed for not prescribing enough, for stopping things, supposing what will happen then if someone has a heart attack that I've stopped their statins in. Will I be blamed? Will I be sued? What if we decide to have palliative care rather than chemotherapy? Will a family member be angry or cross with me? And I think to a certain extent, some of this can be mitigated by honest conversations, but that has to be matched elsewhere. There's no point in GPs saying this on our own. Cancer charities have to support us. Policymakers and politicians have to support us. But I think we should speak truth to power and continue to do so. I mean, this is the ideal person to do CPR in, a young Premiership footballer called Fabrice Muamba, who very dramatically collapsed on a Premiership pitch and was resuscitated and made a good recovery. That is an ideal situation to do CPR. Unfortunately, the Nursing and Midwifery Council in the UK has taken a very, very different view. And this was a report where an experienced nurse working in an elderly care home was noted that a patient had died, had passed away. An elderly lady with multimorbidities had passed away, and she did not attempt resuscitation. She noted that the patient was cold and waxy, and she was censored by the Nursing and Midwifery Council, who disciplined her for not starting CPR. And there have actually been 4 or 5 cases very similar to this. So I can understand nurses being very, very fearful of not doing CPR, even when they know that it is an entirely ridiculous thing to be doing in the first place. So can we get back to what we know is good for patients and what we know is right? So doctors' preferences. What do doctors want when they get older and come into later life? Well, here's a good cohort from America, enrolled in between 1948 and 1964. And I think it's interesting to study what doctors want, because doctors perhaps know in some way the futility of what we do. Even though we still overestimate it, we still have a bit of an idea about the hazards and the problems of too much medicine. And these doctors, as time went on, more and more of them did not want invasive measures. More and more of them had told their family and friends that they did not want to have life-prolonging treatments. They did not want to have antibiotics if they had pneumonia. They did not want drips if they had a stroke. They did not want feeding tubes. They did not want invasive investigations. They'd rather be kept at home. And we know that people say that they would prefer to die at home, and yet we keep over-medicalising them by offering them treatments that can only be given in hospital. It really is a bit of a disaster. And compared with the general population, 64% of these doctors, now over 70, had made advance directives that they had shared with family and friends, compared with only 20% of the population. And what that means is they know that they will automatically get more treatment than they want unless they tell people otherwise. And if that's doctors, knowledgeable doctors, what about the average citizen? How did they get to find out the ineffectiveness of so much that we offer? I really think we have to be much more clear and much more plain about the limited effects of much medicine and actually go back to what really matters at the end of life. And this is what I think we can really do better, really do what we should be able to do. So I think GPs, rather than all that long list of the media to start with, I think what we're really good is demanding evidence for the interventions we do. How much better would the NHS be if we had refused to get involved with so many reforms that have wasted money, diverted resources, and made our professional lives a misery? We are good at sharing evidence. We do it every day in the consulting room. I think we should be doing that much more widely, much more vigorously, especially to policymakers and politicians, and showing them how we can do it better. We need to think critically, much more critically about what is happening. So that Nursing and Midwifery Council decision, I have written to them. I have tried to express my huge concern that this will lead to resuscitation for people who cannot possibly benefit and will just make a situation undignified and unpleasant for everyone, but they're not yet listening. They might not listen to me, but they might listen to 100 or 1,000 people. I think our voices should be much more widely known. I think we should try and make medicine boring. I think so much of the time we are encouraged to think we can do so much with less and less. We should make sure that we know the limits of what medicine can offer and make sure we give people really good, informed choices, particularly about screening well people. The other really amazing thing that general practice can do is build long-term relationships. There's so much research now about the value of continuity of care, how much better care is when it's with someone that you know. It doesn't have to be with the same doctor all the time, but it does have to be with a group or an organisation that you trust and can share information about you. And we know the richness of long-term relationships. How many doctors have suddenly it's made sense when you've met the mother or the sister or the brother of the patient you've been seeing. We understand communities and we understand the longitudinal nature of our work. It makes work much easier, but it also makes work much more joyful. It's such a pleasure to be part of a long-term plan, and patients who know that you're usually good will forgive you if one day you're really grumpy and bad-tempered. We have to tell policymakers, though, fundamentally, that we cannot fix political problems with medicine. We keep being told in the UK that if only we could get more poor people to go for health checks, everything would be better. It's not true. We are giving people things they don't need that can't benefit them. Instead of that, what about safer housing? What about a benefit system that doesn't denigrate and humiliate people as they go through it? It's so inefficient. It breaks my heart to see how poorly managed it is. Transport systems, infrastructure, playgrounds, safe, sustainable transport networks, all those things have profound impacts on people's health. Free school lunches, free school breakfasts make a huge difference to the welfare of our poorest children and cannot be fixed with health checks for adults or mammography screening or bowel cancer screening. And I really fear that our politicians have got it wrong when they come to asking GPs to fix health inequalities. They're asking us to do something that simply cannot be done. And worse than that, when we put so much medicine into preventative healthcare, it's sending GPs on a wild goose chase. We are filling our days with ineffective, low-value activities, stuff that can't help our patients, but is making us more and more busy that we can't get to do the work we know we are really good at. And I think we need to be in charge a bit more. So many GPs have got so much to say and do, have really good experience on the front line of human care. And so seldom, I think, do central policymakers get to hear about that or know about that. For a long time, I've been frustrated that it's only a few GPs that get to speak to policymakers or get to go to conferences or get to interact with the academic community. But I genuinely feel that if more people were to raise their voices and speak up, there would be far fewer problems, and the problems we do have will be fixed with the wealth of information and knowledge that ordinary frontline GPs can bring to it. So we have really big problems in the UK because this man is our Foreign Secretary. This is Boris Johnson. He's not a very good politician. This was the slogan that they used, give our NHS 350 million that the EU was apparently taking every week. It was a lie. It was always a lie. And now we're leaving the European Union. And I feel sick at the thought, to be honest with you. It's not going to help the NHS. We're going to probably lose huge amounts of staff that have come to the UK from Europe. It will likely destabilise the markets economically as well. And I'm really worried about it. So I'm thinking that perhaps there's another solution. So Australia has been in Eurovision for the last few years. So what I'm thinking is Scotland, if we could be part of the Nordic community, if that would be all right. There might be a few English people want to join in as well, if you would be up for that. And 2020, maybe you could think about having your conference in Glasgow, perhaps? Okay, that's... Our alcohol is much, much cheaper. Okay. I'm really grateful to you for listening to me. Thank you so much. I've got Tunnock's tea cakes and postcards if anyone wants one afterwards. Thank you.